Thank you, Mr. Chairman, for this nice introduction. It's my privilege to be here today to talk in a very important topic and difficult and challenging topic that we are facing. And I will walk you, inshallah, through 3 essential steps on how to diagnose and treat a case of ambiguous genitalia. So here in this part of the world, Dominican Republic, there is a chance, 2% chance for every girl to be changed to male at age of 12 years. And those group of people are called guividoches. And this is, okay. And this is the Yemeni version of guividoches. If you look at the picture of this girl when she was 6 years, and this is the same girl when he was in his 13th year. So this will bring us back to our background. What are the determinants of human sex? So there are 5 differences between male and female. وليس الذكر كالأنثى. And those 5 differences are chromosomes. In male, there is XY, Y in female, XX. Gonads in male are testes, while in female are ovaries. Internal genitalia, there are uterus, fallopian tube, and versus epididymis, vas deferens, and ejaculatory duct and prostate in male. External genitalia in male and female are well known, and the gender identity, the female versus male behavior. Okay. Now, this is the sexual differentiation and the development of internal genitalia. As we all know that every embryo has all primordial organs that differentiate into male or female organs. As you see here, there is what is called primordial gonads in both either male or female embryos. And with presence of Y chromosome, those primordial gonads will differentiate into testes in male or in the presence of Y chromosome, while if the Y chromosome is absent, those primordial gonads will differentiate into ovaries. If in the suitable environment or hormonal environment and the presence of testosterone, the phase difference will develop, or we can say the Wolffian duct will develop by the action of testosterone, and it will differentiate into phase difference, seminal vesicle, ejaculatory duct, and prostate, while Wolffian duct will develop in female if there is no testosterone or androgen in general. The external genitalia will develop from primordial organs that are present in both XY or XX embryos. Genital tubercle will give rise to phallus or penis in male and clitoris in female, while genital fold and genital swelling will give rise to labia in female and scrotum in male. Okay, so what is the normal newborn? The normal boy has bilateral descended testes and completely formed, well-developed scrotum with average benign length of 3.5 centimeter plus minus. And the full-term normal female will have bilateral, completely separated labial folds, no palpable gonads, and separated urethral and vaginal openings. So, based on this, we can now decide who should be investigated for disorder of sexual development. So, if you have a newborn with bilateral cryptorchidism in male, bifid scrotum with hypospadias in male, peniscrotal hypospadias in male, or micropenis in a male-looking, or enlarged clitoris in a female-looking newborn, or labial fusion in female, or palpable gonads in female. Those newborns should be screened and investigated for ambiguous genitalia and for DSD. Okay, now we can define the disorder of sexual development, or DSD, that it is the discordance between the genetic, gonadal, or anatomical sex. Now, if this big circle represents the disorder of sexual development, ambiguous genitalia is representing just a part of DSD. While congenital adrenal hyperplasia patient, some of them will be having ambiguous genitalia, and some of them do not have ambiguous genitalia. Okay, this is the classification, international DSD classification in the Chicago Consensus 2005 that classified the DSD into 3 groups. Either this is the first group according to chromosome. If there are any abnormalities in the chromosome, then the case will be 6 chromosomal DSD. And if you see here, you will find Turner and Klinefelter syndrome are part of chromosomal DSD. Okay, in XY DSD, it is also subclassified into disorder of sexual development and disorder of androgen or synthesis or action defect. And the third classification of DSD is XX DSD. If you find a disorder in ovarian development, this is subclassification as well. And if there is fetal androgen excess, as in case of congenital adrenal hyperplasia or non-congenital adrenal hyperplasia, androgen excess that is caused by either maternal or fetal. This is the androgen biosynthesis, and I think everyone here knows this map of androgen biosynthesis in adrenal gland, and here the androgen biosynthesis in testes and ovaries. Okay, there are some steps that are shared between the androgen biosynthesis, either in adrenal gland or in testes. So the father of all steroids, which is cholesterol, can be changed to pregnenolone by the action of STAR enzyme and P450 side chain cleavage enzyme into pregnenolone. Then pregnenolone will be changed to, in many steps, to androstenedione. The androstenedione is further changed in testes by the action of 17-beta hydroxysteroid dehydrogenase enzyme type 3 to testosterone, and then by 5-alpha-reductase type 2 to dihydrotestosterone. So these steps occurs only in testes. Now, if there is any cut in one of these enzymes, and because it is shared step between the adrenal gland and the testes, the first sign you will see that the ACTH will be high in this case. So this is what is called congenital adrenal hyperplasia, and the ambiguous genitalia that associate many cases of congenital adrenal hyperplasia. This is the cause. Okay, this is an important point, that the adrenal gland steroids biosynthesis is stimulated by the ACTH and through the melanocortin type 2 receptor, while the androgen biosynthesis in testes and ovaries is stimulated by LH and HCG through this receptor, LHCG receptor. Those are a very important point that differentiate between the androgen biosynthesis in adrenal gland or gonads. Okay, this is a message for everyone here. Please, if you find or if you have a newborn with ambiguous genitalia, please admit him as an emergency case. Okay, so how can we diagnose now after this tall background? So how can we diagnose a case of ambiguous genitalia? The first of all is to take a history, including family history, because as you know, those disorders are mostly genetic disorders. And then you will do a general examination and genital examination as well. Okay, the first step in diagnosis is to request for karyotype and to do FISH study for SRY gene. SRY gene is a gene that is carried by Y chromosome, and if it is present, that means mostly 99.9% it is carried by Y chromosome. So if it is present, then this is Y chromosome. So karyotype plus FISH study for SRY gene, and in the first step, you should determine what are the gonads. Determination can be done by means of clinical examination, ultrasound, or MRI of the pelvis. If you cannot find a real or an accurate answer, what are the gonads, then you have to go to biopsy. So the step number two is to do biochemical testing, and you should interpret the result. Those are the usually requested biochemical profile in case of ambiguous genitalia: ACTH level, congenital adrenal hyperplasia, biochemical profile, LH, FSH, estradiol, testosterone, and anti-Müllerian hormone level. If results are clear for you, then that's enough. If not, then you should proceed to high-dose ACTH stimulation test and or HCG stimulation test. Okay, by means of these two steps, you will find now the result. This is the normal female, and this is the normal male. Now, if you request karyotype and find abnormality in karyotype, the abnormality will be one of these. So this is the final diagnosis of chromosomal DSD. If you find chromosomes are normal, then you should go to see what is the result of determination of gonads. If you find dysgenesis, regression, ovotestis, mixed gonadal dysgenesis, or testicular XX, then you reach the final diagnosis of disorder of gonadal development. Okay, if chromosomes are normal and gonads are normal in comparison to karyotype, then you will go to internal genitalia. In case of presence of uterus and fallopian tube in XY patient, this is a diagnosis of persistent Müllerian duct syndrome, which is very, very common. Okay, in external genitalia, if everything is normal, in terms of normal chromosomes, normal gonads, normal internal genitalia, but the external genitalia are abnormal, then it is one of two subcategories. Either virilization of XX, and this is called androgen excess, or under-virilization of XY, and this is either testosterone synthesis or action defect. In this case, you should do HCG stimulation test to confirm your diagnosis. In case of virilization of XX, you should do high-dose ACTH to confirm your diagnosis, if initial results are not clear for you. Okay, the step number 3 is to do genetic testing. I know how difficult it is doing genetic testing in Yemen, but it's an important step, especially if you find 1 or 2 or 3 cases in the same family. So genetic testing should be done to confirm the diagnosis, and for rare cases and new emerging condition. And nowadays, the genetic testing is even simpler than it was before. Now they are doing either whole exome sequence or genetic panels for disorder of sexual development, and those genetic panels will give you a good result with minimal effort of thinking what is the type of gene that you should request for. So just you can request for genetic panel for disorder of sexual development. Usually the result will come to you in a very clear way, because they do many genes that might include all the possible causes of disorder of sexual development. So in summary, we have 3 steps to diagnose a case of DSD. Number 1 is to do karyotype and FISH study for SRY gene, and to determine the gonads by means of clinical examination, ultrasound, MRI, or even biopsy if you don't find a good result and accurate result. Then step number 2 is to do biochemical testing, and step number 3 is to do genetic testing. If I have more time, I can discuss one case. No time? We can see one case. Okay, this is a newborn in a labor room, has male type looking phallus with chordae, but the scrotum is underdeveloped. No evidence of hyperpigmentation, and no testes were approached by palpation. There was a single opening located just proximal to a glans, or what is called hypospadias. Now, the patient received the first dose of beta-HCG vaccine. In a second day, then he was discharged in a good condition with his mother. The patient was named Abdullah. At age of 3 weeks, he was presented to ER with vomiting, severe dehydration. He had hypoglycemia and hypotension. Creatine was high, sodium was low, and potassium was high. So initial workup for ambiguous genitalia revealed karyotype was XX. So the patient is Abdullah and his karyotype is XX. The SRY fish study for SRY was negative, and this is making sure that no Y chromosome. And this is the ultrasound to see what are the types of gonads and internal genitalia. As per report, there is a pear-shaped hypoequic structure, which is uterus, and no evidence of pelvic masses, and ovaries or gonads cannot be seen. So in this case, you should determine what the gonads are, either by MRI or biopsy if MRI is not clear. So the initial investigation showed that the patient has high ACTH and high 17-hydroxyprogesterone. This is a very common case of congenital adrenal hyperplasia due to 21-hydroxy deficiency. The incidence of this case is around 1 per 5,000 newborn, very, very highly prevalent in Yemen. So just consider any case of ambiguous genitalia and dehydration in the first 3 weeks of life as a case of congenital adrenal hyperplasia until proven otherwise. And thank you.
Thank you, Doctor. Thank you, Dr. Anas, for the nice lecture and presentation. Now we are welcoming the next speaker, who will be Dr. Zaid.
No, we have a few minutes for questions. خلاص. Okay, no time for questions.
The new chairman is Dr. Najib Abu